So how do we approach a patient who has relapsed refractory diffuse large B-cell lymphoma? I think the first thing we want to know is how fit they are. So are they fit enough for high-dose chemotherapy? So in our centre we tend to use GDP. And if they're fit enough for high-dose chemotherapy, our standard approach at present would be to give them GDP, and if they've got a partial response or a complete response, take them to autologous stem cell transplant. The next question is, if they're not fit enough for high-dose intensive chemotherapy, are they fit enough for CAR T therapy? Because at present, our decision about second-line therapy can impact in the UK whether they will be eligible for CAR T. So if they are not fit because of the high dose intensity, but CAR T fit in a second line setting, I would give them R-GemOx, because for UK panel approval, they have to have failed a treatment of dose intensity of at least R-GemOx or R-Bendapola before going to third line CAR T. I would make sure they'd had a biopsy to confirm that high grade relapse, and I would give them R-GemOx. If I'm trying to get my patient to CAR T, I would avoid bendamustine because we know it causes T cell depletion. If they fail R-GemOx, then I would take them to CAR T, which would be the third line standard of care. And then we have these patients who are not CAR T fit or high dose therapy fit. And for those, we have to have a discussion about what the patient wants. So second line, we can use rituximab, bendamustine, polatuzumab. Do they want to come up to hospital still, or do they want to have an oral palliative approach as an outpatient? Do they want to have a clinical trial option such as a bispecific antibody? Do we look at whether we can get compassionate use of other drugs which aren't yet NICE approved but are EMA and FDA and MHRA approved? So all of these options, it's a pathway, but remembering that we have to think at our second line decision making, that the decision can affect third line options, particularly in the UK.